I'm Chris Motes, and this is Faith in Politics. On this broadcast, we range from the soul to the state as we cultivate those virtues and explore those principles that help us live well as faithful Catholics in this great land. Hey, well, welcome back for another episode, folks. We are in week 2 of the 2022 South Dakota legislative session, and the Capitol is hopping. Everybody is staying busy. There are already, we're in the neighborhood probably now as this is being broadcast on Tuesday, over 150, 160, maybe even more bills filed by Tuesday. It's going to be busy. As mentioned before, money is a big topic of conversation amongst a lot of legislators. South Dakota has had, like many states, an influx of federal cash, coronavirus relief spending money that has come to the state of South Dakota, which has created a lot of work. You know, it's the wisdom in the Capitol is that the easiest legislative sessions are during those years in which the state revenues are a bit leaner, but it gets a little busier and there's a bit more dialogue, discussion, some might say argumentation when there's a lot of money on the table. So we are praying for wisdom, prudence, and charity for all those legislators as they have those conversations that are very, very important concerning the state budget. We are going to talk about an important pro-life topic on the show today. We're going to talk about chemical abortions, sometimes called medication abortions. I don't really like that term because it's not medication. It's chemical violence in the womb. Joining us today to talk about this question is Dr. Glenn Ritter. Dr. Ritter has a family practice in Sioux Falls, is the medical director at a pregnancy help center in Sioux Falls, and now operating, or soon to be operating, throughout the state with a really great mobile unit that they've recently upgraded to. Also, the state director for the Catholic Medical Association. Dr. Ritter, welcome to the show.
Thank you, Chris.
Glad you're here. Okay, I've known you as Dr. Ritter for my whole life, very, very long time. Thank you, by the way, for just taking me camping as a kid. That's been great. I've known you forever. Some people know you as Deacon Glenn Ritter. What's the story there? You've been a deacon for how many years now?
Been a deacon to be 4 years coming up this May.
Congratulations on your diaconate ordination, which kind of raises the question, what do we call you? Deacon, doctor?
Well, sometimes it's too many syllables, so DDR.
DDR. Okay. Not a DDS. That's a dentist.
That's
DDR
it,
is,
yeah.
So Dr. Deacon Glenn Ritter. This question of chemical abortions has come to mind, or is sort of a contemporary news item because of something that the FDA has done recently. So we're going to get to that, but maybe just to start with, can you tell us a little bit about what is a chemical abortion, a medical abortion? What's involved and how does it work?
Well, there's two basic chemicals, and so you can actually call them medicines because they're approved by the FDA as medicines. One of them is used in all kinds of other situations. The second medicine is given. It helps protect stomachs from acid, ulcers, and things, and can be combined with like ibuprofen to protect your stomach. So it's a good medicine in that situation. It's also a medicine that is used in labor and delivery. So people that aren't delivering this medicine, the second one that's given is misoprostol, that actually enhances contractions, matures the cervix and gets ready for contractions at the end of pregnancy so that it helps in delivery. Now, they use that aspect of it in early pregnancy in these chemical abortions because it also stimulates contractions early on to try and expel the products that are within the uterus. Now, it's the first medicine that is fairly new, came out, started to be called an RU486. It's mifepristone, and this medicine actually works against the physiology of the female early in the pregnancy, and later in the pregnancy, it works against the physiology of the placenta of the baby. Both of these, the ovary in the young woman early in the pregnancy produces a chemical called progesterone. And it's a marvelous chemical that builds up throughout the regular reproductive cycle until after ovulation. It kind of peaks and drops off. And when it drops off, the lining of the uterus sloughs in what we call a period for the periodic cycle of the female. Now, this new medicine goes against that. And it goes against when the mother gets to be about 12 weeks along, the placenta is large enough then that the ovary of the female kind of dwindles in its production and the placenta takes over. And the main thing that it does for the lining of the uterus is increase the dose of progesterone throughout the pregnancy. And that progesterone then maintains and builds up the lining of this pregnancy uterus so it can house that child until term. And that kind of dwindles at the end of pregnancy, which some people think maybe that's why women go into labor, because the progesterone causes a drop off. And so then the lining of the uterus might get irritated, and then labor starts and you have a normal, healthy baby. But early in the pregnancy, this mifepristone actually counters the progesterone because it's a progesterone antagonist. So when that is put on board, it tries to basically physiologically drop the dose of the progesterone that the ovary is producing to maintain the lining of the uterus, which encompasses the house of the baby. Yeah. And so when that happens, you drop off the progesterone to say, okay, well, now the uterus cannot keep the lining, and then you cannot keep that connection with the baby, and you lose the baby. Okay, so the baby should die if we compromise the effects of the progesterone that's normally there. And so in that, we compromise the progesterone, drop the physiologic level, basically, and you lose the pregnancy. And then the second medicine, which is misoprostol, that actually enhances contractions. And so they expel then what they hope is a dead fetus.
How does the timing work of this? So we've got these two FDA-approved pharmaceutical drugs. Mifepristone is the first one. I'm just going to repeat back to make sure I understand. Tell me if I get something wrong. So mifepristone is the first one, and that one essentially cuts off the progesterone, which degrades the baby's home in the womb, so that the baby will die in the womb.
Exactly.
Then the second one, misoprostol, is taken at some point in time later, and that's the one that would induce the contractions so that the baby, which is now deceased, is expelled from the woman's body. Is that correct?
Correct.
Can you say more about kind of just like the timing of how this works? Like, what's the time period between when these two drugs would be taken in a medical abortion?
All right. Well, in the state of South Dakota, there is statutes that say that when the woman would go to the provider of abortions, the main one in South Dakota is Planned Parenthood, then they would have to go to be seen supposedly by a physician provider, and that provider then would counsel them. And then if they decide they want to have the abortion after that counseling, then they have to wait 72 hours before they could start that process. During that time, they are to see a pregnancy help center to get the other side of the picture, because Planned Parenthood is notorious for not giving them the other side, that there's other options, there's other things we can support the pregnancy with. But then during that 72-hour period, if they still feel like they're wanting to do the abortion, then they would present themselves again to Planned Parenthood and get the first pill, which the provider, supposedly a physician, is supposed to be doing that. And they would watch the woman take the first pill. Yep. And then in the past, the statute has always said they should be followed up to get the second pill, but Planned Parenthood has been just sending them home with a little baggie with the second medicine in it so they could take it on their own at home about 24 to 72 hours after the first pill is taken. And then after that, they would say, well, they would likely go through the contractions and expel what they would expect to be a dead baby.
So I want to talk a little more about kind of the FDA change and South Dakota law. Before we get to that, though, I want to just take a step back to this first one, mifepristone, and what it does. Can you just describe, sometimes just understanding details I think are helpful. Can you describe like what this experience is like for the life in the womb? Like what is actually happening? What causes the death? What is this child going through?
All right. Well, if you realize that as soon as that conceptus is within the lining of the uterus, it's already about 2 weeks old, has about 100 cells, and it implants into the lining of the uterus. And so we don't live on the surface lining of the uterus. We are embedded deep into the lining of the uterus that is controlled and maintained by progesterone. And so there, then the cells absorb and get rid of waste products and things before the placenta is big enough to take over. And so, again, that's where we aren't dependent on the placenta at that point. We're dependent on the ovary to maintain the lining, just like it maintains the lining in a regular period.
Yep.
And then once the pregnancy occurs, a woman's body is given a signal to maintain that progesterone a little longer than it would if it wasn't pregnant.
Yep.
And that usually is 12 to 13 weeks, something like that, before the placenta is big enough. And so then when that mifepristone is given, then, again, compromises the main support system for the lining of the uterus. And so that disables that connection between the conceptus, the fetus, and the mother. And so that it basically cuts off the lifeblood to the baby.
It's not getting nutrients, it's not getting blood, it's not getting what it needs.
And it's not being able to get rid of any waste products it has. So it's a toxic situation. And so that in nature, about a quarter of all pregnancies are lost.
Yeah.
And most of those happen well before the mother even knows she's pregnant. She might just get a heavier period.
Yeah.
And that's basically because we build up the little lining more than it would have otherwise been. And when she has a period, it's larger and more cramping. And so then a lot of women will go on later in the pregnancy and maybe have what we call a miscarriage, which is a spontaneous thing. Something happened to the lining of the uterus that does similar to what this drug does, and the baby just passes away. Nobody knows because it's early enough. The mother doesn't really recognize maybe that she's even pregnant, and certainly she is not noticing baby kicking and things like that, which usually happens by about 20 weeks.
Yep.
So it basically kind of smothers the child.
Yeah. Yeah. Wow. Okay. So, again, we're going to get to the FDA. I do want to, kind of just understanding this process, this brings to mind for me too, a bill that I think you testified on behalf of last year. It was House Bill 1130. If you remember that one. I know the numbers, we get them confused. So this was the one, they call it abortion discontinuance or abortion pill reversal. It was requiring that a woman be advised that if she has doubts or changes her mind after taking that first pill, the mifepristone, that there may be a chance that she could, if she's changed her mind, that she could save that life and discontinue the protocol. So the reversal is not exactly, because it's not a guarantee. There's not a scientific certainty that you can sort of reverse it, but you can discontinue it and introduce take other medical steps that in some cases can save the child's life. Great law. That's good information that mothers should have at that point. Can you just tell us a little bit how that works?
The reversal, the terminology has been changed because it's the medical intervention is not reversing the effects of mifepristone. It is competing with that medicine. And basically, the only simple medicine that we use to do this is progesterone, that is either driven from yams or soybeans and is almost identical to what the woman produces. It's not harmful at all during pregnancy. We use it all the time to help in women that have had miscarriages or recurrent miscarriages to kind of support that system until the placenta is big enough to take over. And so we call it a rescue instead of a reversal. Yeah. Because we're rescuing this child. And the literature say that up to 80% of the women have regrets once they made this decision. And so then when the medicine is given, then progesterone can be added, and as soon as possible after the first medicine is ingested, the higher the likelihood we are to have success. So the medicine just competes with progesterone, so it's generally not believed to be harmful to the pregnancy unless it kills the child, of course.
Yeah.
Because it kind of smothers the child. So that one of the arguments that the abortion providers would say is that we're increasing risk for abnormalities with the child, and nobody knows that. And so if you give this medicine, basically we just give enough progesterone to compete with the progesterone antagonist that we can still maintain enough of progesterone to maintain the lining of the uterus, which then maintains the pregnancy within that lining of the uterus.
So it'll maintain the pregnancy long enough for the effects of the mifepristone to diminish, and then the body kicks in again, and the child
takes off on its own.
So can I ask you about any success stories? I mean, have you seen this play out?
Yes. As a matter of fact, I happened to be involved in the very first one that was ever attempted in the state of South Dakota about 2 years, almost 2.5 years ago now.
Yeah.
So there was a young woman from Sioux City who became pregnant, and the boyfriend did not want to have her have this baby, so drove her from Sioux City to Des Moines because there was no provider of abortions in Sioux City. And so she took the pill at about 1 o'clock on a Friday afternoon, about 2.5 years ago. And she was supposedly about 8 weeks pregnant. And on her way back from Des Moines to Sioux City, she had her regrets already. There is an abortion reversal hotline that's national, and they try and hook the women up to somebody regional or locally that could do something to help with this rescue process. And that happened to be me, being educated through the Catholic Medical Association on how to do this, probably a couple years before this happened, but never having done it. And I have worked with a lot of pregnancies in my tenure, and so I had the progesterone in my office, the progesterone that we would use to turn this around. And I had all the protocol in my office. And so I was called Friday afternoon. I'm off work. And she was certain that she wanted to do this rescue. And so she took the pill at 1 o'clock in the afternoon. And by 9 o'clock that night, she was in my office. And so, yeah, she knew she wanted to reverse this process. And after visiting with her, found out some very interesting things about her, that she was Catholic. She belonged to a Catholic parish in Sioux City. She was Hispanic, a wonderful little gal, and was very certain she wanted to try and maintain this pregnancy. So after visiting with her, we started the protocol in which she had to show up both not only Friday, the day that she was there, but Saturday and Sunday, and then twice a week until she was about 14 weeks along to get this treatment. And the treatment was pretty good-sized doses of progesterone. That's commonly used in pregnancy for the same reason, to maintain pregnancies who are spontaneously miscarrying. And so she did this. And the first night she was there by herself. The second day she was there with her sister. And the third day, Sunday, she was there with her parents who wanted to see if I was real. And we did an ultrasound the following week, discovering that she was due on the feast day of Our Lady of Guadalupe.
Ah, praise God.
On 12/12.
Oh, my goodness.
And I was supposed to preach that coming weekend, and so her story was used in my homily that was okay with her.
Yeah.
And so after we had the protocol going for a little while, then I turned her over to a physician down in Sioux City that would take her through the rest of the pregnancy. And she delivered little Roman not on the Feast of Guadalupe, but on December 8th. Immaculate Conception.
Oh, my goodness. Wow.
So do you think there's a plan for this little boy, Mr. Roman?
Amen.
And I've had birthday cake delivered to me from Sioux City for his first birthday, and just a few days ago for his second birthday.
Wow. Wow.
So he's a marvelous little 2-year-old.
Healthy
Little boy. Rambunctious as all 2-year-olds.
I have one right now. That's great.
So yeah, it's very successful. And the protocol by some studies would say it's about 70% effective at rescuing these pregnancies, to the point where a lot of pregnancy rescue clinics are now set up as close as possible to Planned Parenthood as they can around the country.
Well, and that's so good, because Planned Parenthood is wanting to do more and more of these chemical medical abortions, even to the extent of now you see these online places they're popping up other parts like Europe, and they're shipping these chemicals to women. I've recently seen articles about them very explicitly acknowledging they're doing this in Texas to circumvent Texas law, and could be doing it in South Dakota too. Which kind of brings us up to, we've got about 8 minutes left. We got to talk about the FDA. Can you tell us what the FDA has done in the last year with regard to these drugs?
Well, the FDA kind of, as a response to COVID, it sounded like, so that we're seeing a lot less face-to-face, realized that this misoprostol, the second med, has been around for years and is very safe. And so they said, well, we don't really need to control this.
Yeah.
And the first one, I don't know how they sidestepped the issue on the mifepristone, but they decided that we can almost do like telemedicine and send the drugs out mail order.
Yeah. So in South Dakota, so we've got that first initial consultation. They come back the second time. They got to see the same doctor, because that sounds like good medical care to me.
Correct.
The first drug would be taken then, mifepristone, and what the FDA is trying to make possible is that you go home and you take the second one at home, which sounds kind of frankly lonely and scary.
Oh, exactly.
And what South Dakota has done recently through this rules process, and I think there's probably a statute coming at some point, is a requirement that the misoprostol be taken at the medical facility as well, in the presence of a provider. Can you tell us why that might be important?
Well, it's kind of like if you even compare it to a miscarriage, the body does a very good job. If you're just spontaneously miscarrying the child, intervention is oftentimes not needed medically, surgically at all, because the female, wonderful, dynamic body can take care of this very nicely on its own.
Yeah.
And in a much more timely and safe way.
Yeah.
And so when we see that patient for that third visit, when the abortion provider would see him for that third visit, you could find out, did the woman miscarry already anyway?
Yeah.
We could do an ultrasound and say, okay, well, you're losing the pregnancy all by itself. It's leaving on its own. You're already doing some cramping. We don't need to implement this drug, which oftentimes leads to a very violent labor and contractions to deliver this dead child. And what Planned Parenthood say, in the comfort and surrounded by their support in their own home.
Mm.
And there's many stories where women are very upset because it is very violent contractions and bleeding. And if they are hemorrhaging in their own home, they're generally not surrounded by people, because this is a secretive thing. Nobody admits that they're pregnant or that they're aborting. And so they are surrounded by nobody.
Mm.
And so they're going through a tremendously traumatic time, a torturous delivery of this supposed dead fetus. And it would make much more sense to look at the woman before that, see if she has changed her mind, which a lot of times they have, and to look at it with an ultrasound again and say, well, what's going on? What's happening?
Yeah.
And so it does. It makes good medical sense that you don't just throw meds at people to take at home that are going to cause significant problems.
Well, when I was reading the FDA's fact sheet about, this change, and what they're talking about is patient access, which to me, that kind of sounds like maybe some political speak for more abortions. And they say there are risks, but they're balancing the benefit of patient access against risks that they're saying, like these major complications, like a 0.4%. So it's not enormous, but still like 1 in 200 women maybe with a major complication. Like it sounds like, and what you're describing is it's not necessarily the most pleasant thing in the world. And
no.
It's very serious too.
Yeah.
What looking at kind of our South Dakota abortion numbers, if I can just for a minute, we've seen a really good trend in our numbers, positive. 2019, 414 abortions in the state of South Dakota. Just tragic. 332 of those were South Dakota women. The rest would maybe be coming in from Sioux City or southwest Minnesota. 2020, there was pretty significant decline, perhaps attributable to coronavirus. The Planned Parenthood was closed for some time, down to 125 abortions, 106 of those South Dakota residents. Do you have a sense of how many of those, and I think the data is available somewhere, I don't have it in front of me, roughly how many of those would be chemical abortions like we've just been talking about?
Well, one of the things is the recording. You don't know how accurate it is, especially if they're just getting mail order medicine. Are they really recording that? No.
Yeah.
Are you certain you had the miscarriage? No. So most of those are probably still recorded as the surgical abortions. And so the numbers are skewed. We think that we're doing really good when, in fact, a lot other of abortions are done with this medical means. And so the numbers appear to be down, but that may be very deceiving because of the reporting process. And the whole idea of this, inconvenience of having to come back in and see the same provider for this third medicine, which just boggles my mind. That when has inconvenience ever been, a factor in medical care?
Right.
And I said, well, you get up every morning, that's inconvenient, but you kind of do it anyway.
Yeah.
And certainly, as a physician, you come in and you're taking call and maybe up nights, taking care of patients, which is certainly inconvenient, but it's for the betterment of the patient.
Yeah.
And so that when they're talking about this inconvenience with Planned Parenthood, it would be much more likely that it's inconvenience on the part of the provider.
Yes.
Because I have to show up again.
Yeah.
And as far as the woman, that inconvenience can be very educational to say, yes, you need to come in and we need to figure out where you are. What's this doing to you? Do we need the second medicine at all?
Yeah. Yeah. Well, a lot going on there, and hopeful that we'll see a statute kind of come to address the same issue and just solidify some things in South Dakota law. Deacon, Dr. Glenn Ritter, thank you so much for joining us on the show today.
Well, thank you very much for having me, Chris.
And thank you, as always, dear listeners, for tuning in. It was great to have you with us. We'll be back next week with Dr. Chris Bergwald. We're going to talk about some of the moral components of the bills we're seeing up in the Capitol. And as always, we love to hear feedback. Reach out, sdcatholicconference.org. You can now find us on Twitter at sdcatholicconf, C-O-N-F there at the end, and Instagram, Facebook, and YouTube. Until next time, live well.